is about pathology and laboratory medicine. إيش أهمية laboratory medicine and pathology, and it's very important in all, in every hospital, some large hospital or small hospitals. So pathology in general, we can divide it into anatomical pathology / histopathology and clinical pathology. البروجرام اللي هنتكلم عنه it's anatomical pathology. Clinical pathology طبعا في تحته other branches such as hematopathology اللي هو علم أمراض الدم, microbiology, biochemistry, what else, immunology. So this is included in clinical pathology وهم عندهم their own programs. إحنا our program اللي هو علم الأمراض التشريحي أو علم الأمراض النسيجي is called anatomical pathology or histopathology. طبعا هذا اللوجو من السعودي Saudi board من Saudi Commission for Health Specialties ويب سايت. حتلاقوا لو رحتوا الويب سايت البروجرام اسمه علم الأمراض or anatomic pathology. So إيش هو anatomic pathology or histopathology? What does it mean? It's the study of organs, tissues, and cells in normal and pathologic states. So we deal with organs, with tissues, يعني اللي هي الأنسجة والخلايا. We deal also with cells اللي هو بنسميه cytopathology. إيش بيسوي الباثولوجيست؟ يعني if someone is specialized in pathology or the pathologist, he or she is in charge of tissue and cell interpretation, cancer diagnosis were part of our job, but we do also non-neoplastic diagnosis. Also, we do accurate diagnosis and staging of cancer cases, which is very important, critical for planning patients' management and follow-up. So we are also helpful to other physicians in accurately diagnose non-neoplastic lesions. So that's why we need competent, dedicated, and safe pathologists. So back to our program, anatomical pathology. طبعا I كنت program director for the past 2 years for the Saudi board and KSU programs. Now Prof. Ahmed Hamidi is the new director. نواف اللي هو طبعا كلمني قال لي انه انت تعرف عن البروجرامز ايش البروجرامز available. في اللوكال programs عندنا السعودي بورد بروجرام، في عندنا في الجامعي اللي هو الكيسيو بروجرام، في بروجرام في الدمام جامعة الإمام عبد الرحمن بن فيصل. So let's start with the programs that we have here in Riyadh. طبعا السعودي بورد بروجرام في 3 centers في الرياض جدة وفي المنطقة الشرقية. بالنسبة لكيسيو بروجرام هذا طبعا عندنا هنا في الرياض في كيسيو في كينج سعود يونيفرسيتي، وفي طبعا حق الشرقية. طيب إيش الفرق between the Saudi board and the KSU? What are the differences and what are the similarities? Both are 5-year postgraduate training program in anatomic pathology, and they are both divided into 2 parts. Junior residency, the first 2 years. طبعا بعدين إذا سمعتوا في part 1 and part 2 exams. عندنا في الباثولوجي part 1 ممكن after 2 years أو after 3 years يتاخذ. فطبعا this is the 2 years اللي هو junior residency, then the senior residency اللي هم final 3 years. It's a joint program, so both for the Saudi board and the KSU. They are joint programs. That means they involve rotations in different regional hospitals. اللي هم الهوستلز عندنا في الرياض. تختلف إيش المستشفيات اللي مشتركة في التريننج، بس basically we have طبعا المستشفى الجامعي التخصصي، الحرس العسكري، مدينة الملك فهد الطبية، وهذه السنة الشميسي. قوى الأمن كانت موجودة وطلعت، فيعتمد. فهذا معنى إنه joint program. يعني الريزيدنت لازم يدور على كل المستشفيات هذه، بغض النظر عن الفاينانشال سبونسرشيب أو الوظيفة، إيش المستشفى اللي هو متوظف عندها. So that's what we call joint program. طبعا بعدين بالنسبة للكيسي والسعودي بورد the same. بالنسبة للروتيشنز على الهوسبيتالز through the 5 years. Assessment and exams, they are different between these two programs. هل ممكن ناخذ ال 2 programs؟ أول كان ممكن، بس الحين صار في new rule إنه you have to apply to one of them. Okay. So what are the requirements? بالنسبة للسعودي board, you can go to their website. طبعا انتوا لما حتبدأوا التقديم حتشوفوا التواريخ حقت التقديم وحقت المتى تطلع النتائج ومتى حتصير الانترفيوز. التواريخ تكون موجودة كلها على الويب سايت. شروط القبول والتسجيل طبعا هذه البيزك، أتوقع لكل البروجرامز إيش ال requirements. بالنسبة للكيسيو طبعا احنا عندنا الكيسيو program يكون الابليكيشن ثرو اللي هو البوست graduate center. these are the requirements. طبعا برضو هي general requirements CV internship certificate MBBS certificate SLE exam transcript اللي هو حق الجريدز. طبعا احنا بالنسبة لنا في الباثولوجي سبيشالي إيش الحاجات اللي نحتاجها اللي تكون يعني we look at في القبول. طبعا بساعدكم إنه كان في elective rotation. أغلب اللي بيجوا يعني في الغالب إنه كل اللي بيقدموا الباثولوجي they are to show their interest أو حتى to know more يعني to get better idea about what is pathology أو internal pathology, what do pathologists do. شوفوا residents what they are doing، لأنه أنتوا طبعا during basic years يمكن ما عندكم فكرة واضحة عن طبيعة الباثولوجي أو what they do. فطبعا like we look at this, you know, if the resident or the applicant had elective rotation or not. And then the recommendations, of course, from pathologists. وإذا سووا مثلا during the internship أي presentations أو راح conferences publications. طبعا هذه كلها تنحسب في أول حاجة في الacceptance وبعدين في الماتشنج يعني وبعدين في الانترفيوز. انتوا عارفين البروسيس. بعد الابلكيشن هتطلع نتيجة الماتشنج، وبعد الماتشنج حتجينا الليست وحنعمل انترفيوز. فهذه هي الأشياء اللي احنا نعطي عليها points. بالنسبة للانترفيوز طبعا حيكون في basic questions like any other interviews، وحتكون يمكن في simple questions about basic pathology، الحاجات اللي هي تكون basic تكون يعني أخذتوها في through the اللي هي first years أو basic years. طبعا زي ما قلنا احنا عندنا في 2 programs. فبالنسبة للسعودي بورد حتكون في له interviews مختلفة، والكيسيو حتكون له interviews. مع الكيسيو ما في matching، حيكون في application بس للدوكيومنتس. وبعدين في interviews والresults توصل direct by emails. فطبعا عندكم two pathways. أول حاجة اللي هو إيش البروجرام، والother pathway الجوب أو financial sponsorship. طبعا هذا بالنسبة للlocal programs. وفي ناس اللي مثلا they want to go abroad برضو لازم financial sponsorship أو job أو they apply اللي هو البعثات. فهذول حاجتين طبعا two pathways. بالنسبة للjoint programs نظن نحفف على كل المستشفيات بغض النظر عن السبونسرشيب. بالنسبة للماتشنج طبعا احنا بعد ما نسوي الانترفيوز في مثل برنامج الهيئة، لأن برنامج الهيئة مشترك، حتكون الانترفيو فيها البروجرام دايركتورز من كل الهوسبيتالز، وبعدين حيصير في رانكينج، وحسب الرانكينج حيصير في توزيع على المستشفيات. بالنسبة للناس اللي already عندهم مثلا job في another hospital اللي هي ما تكون من ضمن ال training hospitals برضو هيكون لهم academic sponsorship. لازم from one of these hospitals participating in the training. طيب هذه بالنسبة ل local programs. طبعا في نفس الوقت اللي كنا نسوي فيه training في السعودي بورد والكيسيو في other مثلا certificates أو exams that you can take. في عند العرب board والبورد عربي. هذا الويب سايت you can visit their website if you like. في عندنا fellowship في Royal College of Pathologists اللي هو from UK ال FRC path. في الإكزامز ممكن في first part second part، في أشياء ممكن تاخذوها من هنا، وفي أشياء you have to travel to take them. وفي عندنا برضو ال RCPA. This is Australian board. نفس الشيء ممكن يابلاي وتحسب التريننج هنا، وبعدين بس you go for the exam. أما بالنسبة if you want to go abroad في مثلا كندا or USA you can visit those websites to تعرف requirements. يختلف البرنامج في كندا عن أمريكا. في كندا هو 4 سنوات، يكون pure anatomical pathology أو histopathology أو and cytopathology. بينما في اليو اس اي تكون 4 years APCP يعني anatomical pathology / clinical pathology. فما يكون pure anatomical pathology، يكون مع clinical pathology اللي هو ال other branches اللي كنا بنقول عنها microbiology immunology biochemistry. okay. طبعا بعد ما الواحد يخلص البورد سواء سعودي بورد أو from abroad or any kind of board هتيجي بعدها ال subspecialties. طبعا هذا حيكون general pathology أو حيتخرج as a general pathologist. بعدها حتيجي مرحلة اللي هي subspecialties or the fellowships. طبعا في a lot of specialties أو subspecialties. وإحنا طبعا محتاجين، في عندنا احتياج كبير في الباثولوجي والسب سبيشاليتيز. طبعا هذه حتتاخذ عن طريق الفيلوشيب غالبا حتكون between 1 and 2 years maximum. بالنسبة للنيوروباثولوجي اللي يبغون نيوروباثولوجي في بعض يكون يا عن طريق فيلوشيب أو أحيانا يكون البروجرام منفصل زي في كندا نيوروباثولوجي بروجرام منفصل لوحده. So this is about our program, and good luck. This is my last slide. If you have any questions, you can ask.
شكرا لك دكتور أماني. قبل ما تجينا الأسئلة ممكن أسألك سؤال أنا، وش اللي خلاك يعني تختارين الباثولوجي؟ وش اللي كان خلاه انترست لك؟
يعني هذا السؤال هو اللي الحين المفروض نسألكم هو في الانترفيوز غالبا يعني. فأنا اخترته because it's very challenging. صراحة pathology is very challenging. يمكن بعض they think it's simple easy. بالعكس it's very challenging, especially طبعا على mental level. ما هو يعني ما في physical input كثير. يعني الواحد يكون في الأوفيس مع الميكروسكوب مع الكتب. That's why I chose it. I like reading. We read a lot. We do analytical thinking a lot. So maybe that's why I chose it. طبعا في أشياء تعتمد برضو على personality. الواحد يعني يشوف إيش اللي يناسبه ويختاره.
جميل جميل. طيب عندنا أسئلة الحين. السؤال الأول يقول لك are there any no programs that offer A B C B in case A؟
لا بس في عندنا program اسمه clinical pathology. تقريبا هو ممكن تسألوا فيه ما أعرف إذا حتاخدوا عن clinical pathology. في أحد حيكلمكم عنه؟ I don't know. بس إحنا عندنا program اسمه clinical pathology per se. هذا جديد هنا عندنا في KSU. طبعا برامج clinical pathology اللي هي زي مثلا hematopathology, microbiology, biochemistry. وفي برنامج كذا اسمه clinical pathology. هذول 4 programs موجودين عندنا في KSU فقط, ما هم موجودين في الهيئة. طيب فعندنا برنامج اسمه clinical pathology ممكن تكلموا فيه يعني تعرفوا معلومات أدق عنه. أتوقع دكتور عمر المقرن أو دكتور أسامة خوجة هم اللي ماسكينه. فهذا clinical pathology يأهل يطلع يعني هم ياخذوا rotations في كل لاب, بس حاجات يعني مثلا لما يجوا عندنا بتكون very superficial, يعني ما يقدر يصير باثولوجي ولا يقدر يقرأ ريبورتس ولا يقدر, بس ياخذ فكرة. يعني هذول ممكن يصيروا في المستقبل يدخل أكثر في المانجمنت والادمنستريشن, يعني يكونوا عارفين أكثر عن كل اليونتس of the lab. وبعدين في عندنا ترى هيماتوباثولوجي, هذا متخصص علم أمراض الدم. هذا برنامج لوحده في الكيسيو بس ما في الهيئة. في مايكروبيولوجي وفي ميديكال بايوكيمستري, هذول different ما لهم علاقة بالاي بي. احنا عندنا اللي هو الاي بي اناتوميكوباثولوجي في 2 programs, واحد خاص في KSU. طبعا this is very old, هو اللي older KSU program. السعودي بورد يمكن بدأ في 2008 أو 2007.
جميل. السؤال الثاني يسألك كيف اللايف ستايل؟
معلش مين اللي بيكلمني نواف؟
عبد المجيد, أنا الأورجنايزر اليوم.
أوكي. لايف ستايل
يسألون كيف اللايف ستايل معك يعني.
والله يعني أنا بالنسبة لي أقدر أقول إنه هو ناسبني من ناحية يعني بالنسبة لي إحنا هنا في الجامعي خلينا نقول إنه ما عندنا أون كولز اللي هو النايت ديوتيز. في other hospitals فيعتمد على الهوسبيتال, يعتمد على السب سبيشاليتي. في مثلا أنا dermatopathologist, إحنا يعني إذا وفي مستشفيات يعني مثلا ماشية بس في السب سبيشاليتي, في مستشفيات لا إحنا نشوف جنرال بلس سب سبيشاليتي. فمثلا لو أنا كنت بس أشوف dermatopatology ما أتوقع أبدا في عندي emergency calls مثلا. مثلا الرينال لا, أو الترانسبلانت باثولوجي لو مثلا اشتغلت في تخصص مثل transplant pathologist أو اشتغلت في مكان في سنتر في liver transplant و kidney transplant ممكن يكون في night duties on call. بس هي طبعا لا تقارن مثلا بال on calls أو night duties حقت surgery أو مثلا other specialties.
جميل. سؤال يقول لك could you get your email؟
شو أكتبه يعني؟
أنا بكتب, أنا أعطيني إيميلي.
هو هنا في type answer
عشان نحطه في الشات عشان الكل يشوفها. لو كتبنا هنا يمكن ما يطلع لهم.
ما يطلع لهم. طلع ولا ما طلع؟
أتوقع يطلع لهم.
برضو ممكن تجوني في مكتبي, يعني إذا في مكتبي في pathology department anytime. أنا سواء أنا أو بروف حميدي. في مكتوب كمان كم سنة الفيلوشيب غالبا سنة أو سنتين ماكسيموم. I did dermatopathology, it was only 1 year. بالنسبة للباثولوجي طبعا أنا ممكن أقول لك إن أنا تخرجت من جامعة الملك عبد العزيز. بعدين دخلت local program Saudi board. I took both Saudi board and KSU. خلصت في 2013. بعدين went only for 1 year dermatopathology. طبعا بالنسبة أنا رحت أمريكا. ما احتجت لأن إحنا في الباثولوجي ممكن أعطونا ما نحتاج إحنا ما عندنا patient ما عندنا patients وكذا، فما نحتاج اللي هي اللايسنس حقتهم. يعتمد على السنترز. فأنا لقيت سنتر ممكن أعطتني fellowship من غير اللايسنس حقتهم يعني.
جميل. في سؤال: what is the acceptance rate for pathology at KSU? How many apply and how many do you accept at the center? Do you have any idea?
السعودي بورد ما أعرف كم اللي يقدموا يعني، بس مثلا خلينا نقول last year أعطونا مثلا أتوقع 16 يعني هذول اللي يدخلوا ماتشن ويسوون interviews، بس إحنا بالنهاية أتوقع اخترنا 12. يختلف هو من سنة لسنة حسب كل مستشفى كم عندها position. غالبا خليني أقول أتوقع 12. بعدين حيكون في ناس على الويتنج ليست، في ناس سحبت، في ناس ما جات. في الويتنج ليست يبدأوا يدخلون.
جميل. في سؤال أخير أتوقع ما له علاقة شيئين. Do you offer research opportunities for undergraduates?
في الديبارتمنت هو أكيد في يعني، بس لازم يجوا students يعني they approach اللي هم الconsultants يكون عندهم ideas، أو إنهم هم مثلا يكون الconsultant عنده idea يعني ويمكن محتاج إنه يتعاون مع الستودنتس.
جميل. خلصنا كذا الكيو&اي. هل عندك في أي شيء تبغين تضيفينه دكتور أماني؟
لا صراحة ما في شيء بدي أضيفه، لكن أوكي خلينا نقول يعني إن إحنا we need pathologists in all subspecialties. ويمكن بالنسبة للباثولوجي بالنسبة لكم ما تعرفوا عنه كثير. أتمنى إنه تكون عرفتوا عنه الحين فكرة. وشيء ثاني ممكن تجوا department anytime تشوفوا تعرفوا أكثر إيش يسوي الباثولوجيست، تعلموا حتى لو مو من consultants من residents تشوفهم إيش يسووا. وإن شاء الله يعني إنه نشوف ناس منكم pathologists أو يعني نشوفكم عندنا في البروجرام.
ممتاز. الله يجزاك خير دكتور أماني، شاكرين لك. كان عندنا سيشن إن شاء الله عن راديولوجي على الساعة 5:30 مع الدكتور لطيفة، أو أول ما تجي إن شاء الله. السلام عليكم دكتور لطيفة.
أيوة أهلين وعليكم السلام.
أهلا وسهلا، جاهزة نبدأ؟
Yes sure. أسوي share screen.
أوكي.
ثواني بس. Can you see my screen now?
Not yet. مو واضحة له.
You can see it now, right?
إيه هي واضحة.
Okay. So بسم الله، اسمي لطيفة الفهد. R3 من جامعة الملك سعود، مستشفى الملك خالد الجامعي. Diagnostic Radiology. ما إيش كان جاهز، ما أدري إيش صار. بكلمكم شوي عن راديولوجي. أنا ما أدري هل الآن the floor is open ولا بعدين في الأخير you can talk to me so we
تفضل
can
بداية
discuss.
تتكلمين تخلصين السلايدز والكونتنت، بعدها يمكن 10 دقائق أو الوقت اللي يناسب Q&A's يكتبونها وناخذ منها، واللي يبغى يرفع يده وعلى طول نرفع الميوت ذم ويسألوا السؤال اللي عندهم.
Okay, good. Okay. ما أعتقد بيسوي full screen فخلاص مو مشكلة. Okay. بتكلمكم كذا على السريع بالأشياء اللي إحنا نسويها في radiology program. It's يعني basically a 4-year program. Okay, so this is not going to work. I will talk. إن شاء الله يعني I don't bore you. يعني ما راح أقول كلام كثير، بس بيعطيكم البيسكس اللي تخص البروجرام itself. يعني زي ما قلت لكم it's a 4-year program in general radiology. فلما تخلص ال 4 years هذه you're going to be a general radiologist. You're not going to work in a specific field زي مثلا breast imaging ولا interventional radiology. No. After these 4 years you need fellowship to specialize in one of the subspecialties that I will talk about. Or you can just work as a general radiologist in any hospital. So they rotate you between specialities as you are needed يعني. فالspecialties اللي عندنا are neuroradiology that you're going to take every year. هذه basic يعني. neuroradiology يشمل MRI, CT. ما عندنا ال MRI CT في النيورو. شغلنا ما هو مقسم على حسب الموداليتي، مقسم على البادي systems. بعدين في chest is extensive في الراديولوجي، نسوي كثير chest. كل سنة في R3 I think. والchest يشمل X-rays و CTs. Again it depends on the body system إيش الموداليتيز اللي نستخدمها في البادي system هذا. عندنا rotation body اللي هي abdomen و pelvis، فيها MRI وفيها CT وفيها X-rays. بعدين عندنا musculoskeletal imaging which is concerned with bones, with muscles. وهذا يشمل X-rays و MRIs وحتى ultrasound. وعندنا breast imaging اللي هو breast ultrasound و breast mammogram. عندنا fluoroscopy اللي هو يكون تعرفون كلكم الفلوروسكوبي اللي زي باريوم سوالو، باريوم ميل، كونتراست انيمال، الأشياء هذه سواء للأدولتس أو البيدياتريك ايج جروب. بعدين عندنا سبيشال يعني سبيشاليتي كذا اسمها بيدياتريكس. everything to do with children including يعني ultrasound, x-rays of any body part ما عدا الهيد تبع النيورو. anything else you're going to do it in pediatrics. So it's a special rotation that you do everything in. You rotate between ultrasound, x-ray, CT, MRI for whichever body part in that child. بعد عندنا nuclear medicine which is يعني a whole new world بعيد شوية عن باقي أشياء radiology. That is also 1 month each year. إحنا عندنا كل روتا 1 month، ففي السنة الواحدة عندنا 12 روتاز. بعدين عندنا AR radiology. هذه برضو a special rotation that you cover cases coming from AR that are not including neuro. بعدين عندنا كذا الحالة فجأة ultrasound, adult ultrasound. يعني هذا أي ultrasound في الحياة بغض النظر which body part you're going to cover. يعني تقسيمة الروتا عندنا شوية عجيبة، بس بشكل عام we go with body parts. بعد عندنا كذا special rotations للsenior years زي interventional radiology. ممكن تسوون 3 rotations. That's a total of 3 months just to know the basics. في الأخير يعني when you finish the program you're going to be a diagnostic radiologist, not an interventional radiologist. You need special fellowship for that, but you're going to be able to do basic interventional procedures if you need it. بعدين عندنا cardiac imaging هذه برضو for later years. وعندنا research يعني it's a requirement. بعدين الحين بدي أتكلم عن البروجرام. في البروجرام structure as well عندنا R1. لما تبدون عندكم أول 4 شهور هذه prep rotations ما راح تنعاد لكم بعدين. زي عندنا rotation اسمها general CT. هذه we don't call it anything، بس تروح تشوف التكنولوجيز كيف ياخذ الإيمجز، تتعلم كيف الراديشن يشتغل، كيف نعطي الكونتراست كذا. كان أول 4 شهور الديوتيز حقتك مرة بسيطة جدا في R1. حتى ما عندك on call duty أول 4 شهور. يعطونك attachment on call just to train you. بس ال on call duties تبدأ بعد أول 4 شهور. بعدين من R1 إلى R2 في yearly promotion exams. حتى لو عديت ال part exam you have to take the promotion exam every year. for R1 و R2 you're going to be treated as a junior. You're going to have junior on call، يعني بمعنى أن أنت الفيرست on call في المستشفى حقك. طبعا يعتمد على إيش السنتر اللي أنت بتروح له. وطبعا الجونيور on call هو اللي يكون عليه اللود، اللي أنت بتستقبل مكالمات كل المستشفى إذا يبغون يطلبون أي whatever emergency imaging modality مفروض تتسوى وقت الأنكول. زي مثلا عندهم appendicitis هذا مرة common، brain bleeding، أشياء زي كذا. بعدين if you want to go from your junior years إلى your senior years you have to pass part 1 exam، وبعدها عندنا part 2 exam after R4 obviously. آخر شيء بقوله عن program structure إن الراديولوجي عندنا all radiology، يعني ما فيه outside rotations برا الراديولوجي. ما في تسوي medicine، ما في تسوي surgery، ما في أي شيء ثاني. It's all in one department. أوكي، كنت بتكلم عن training centers وصراحة كان عندي صورة نشوف يمكن يضبط الحين. ياي good. هذا الكلام اللي كنت قلته وصراحة ما ودي أعيد عليكم. هذه specialities حقتنا، وال on the other side اللي بالأبيض هذه special rotations اللي يأخذونها seniors. I will pass this. خلاص تكلمنا عنه وكلمتكم شوية عن ال structure حقتنا وكيف تنتقل. طبعا كل specialities غالبا يمشون على هذه الخطوات، و it's all radiology no outside rotations. أيوة. بالنسبة للtraining centers إحنا عندنا 9 training centers، هذه جايبتها من موقع الهيئة. عندنا الحرس، مدينة الملك فهد الطبية، تعتبر تبع وزارة الصحة. عندنا التخصصي، قوى الأمن، مستشفى الملك خالد الجامعي اللي تبع جامعة الملك سعود، العسكري والشماسي، مستشفى دلة تو جديد، ومستشفى سلمان. إحنا في الراديولوجي نعتبر يعني قبل سنة كنا joint program، بمعنى أنه تقريبا every 5 hospitals are 1 tract، إحنا كنا 2 tracts. فعلى سبيل المثال إحنا كنا في التراكت التخصصي، معنا مستشفيات أخرى زي العسكري كذا، كنا نطلع لهم إجباراً. إحنا عندنا 12 روتيشن في كل سنة، ممكن 3-4 روتيشنز بيطلعوني برا السنتر حقي بالإجبار يعني because it is a joint program. الآن الوضع تغير، صارت سنترز كثيرة separate، زي إحنا الجامعي صرنا separate، الحرس separate، التخصص separate. صراحة ما أعرف عن الباقيين إيش صار كيف وضعهم. في programs لسه joint لأن ما عندهم كل rotations in their center، زي مثلا مستشفى الملك سلمان ما عندهم some rotations، مستشفى دلة ما عندهم، you have to go outside of your center to get the benefit. على سبيل المثال cardiac imaging ما هو موجود إلا في أماكن معينة، so you have to go out to do those rotations and satisfy the requirements. هذه السنترز. بالنسبة لللايف ستايل في الراديولوجي، إيش نسوي إيش ما نسوي؟ يعني أبى أشرح لكم one normal day in radiology. أغلب السنترز أو مو بأغلبها، نص السنترز تقريبا عندهم زي المورنينج ميتينج، تجي الصباح، والمورنينج ميتينج هذا يا إنه زي عندنا في الجامعة يعرضون حالات الأنكول، في الحرس مثلا عندهم لكتشر، على حسب السنتر يعني. وفي سنترز عندهم ما عندهم مورنينج ميتينج بس عندهم مورنينج ساين إن، وفي سنترز طبعا ما عندهم لا مورنينج ميتينج ولا مورنينج ساين إن، تقدر تجي أي وقت، الساعة 9 الساعة 10 على حسب شغلك. ف this is nice يعني. بالنسبة للسنترز اللي ما عندهم هذه requirement. الساين اوت برضو في سنترز عندهم، في سنترز ما عندهم. أغلب السنترز ما في ساين اوت، متى ما خلص شغلك you can just leave. بالنسبة للwork load it depends on your level. كل ما هذه يعني مشكلة صغيرة مرة في الراديولوجي، إن كل ما طلعت level كل ما زاد ال expectations عليك، وكل ما صار ال work load عليك أكثر. بمعنى إحنا الهيئة يقيموننا على حسب عدد الحالات اللي إحنا نكتبها. طبعاً إحنا منا بسيرفيس which is a good thing، هذا من أحسن الأشياء في نظام الهيئة عندنا، إنهم عشان يمنعوننا نصير سيرفيس ونتعلم أكثر، رغم إنه في سنترز فيها سيرفيس أكثر مما هو شغل، بس all in all إحنا مثلاً required to satisfy a specific number of things. يعني مثلاً R1 مفروض يكتب 15 X-rays in one day بس. إذا كتبت 15 خلاص this is your goal، you can just discuss whatever you wrote and then go home، سواء خلصت ال 15 هذولي within the work hours ولا بتجلس بعد الساعة 5 ما تفرق. يعني إحنا عندنا زي ال requirements for each speciality for each modality. مثلا MRI لازم تكتب 5 وهكذا. فالwork load صراحة يعتمد على الروتة نفسها وعلى المستشفى اللي أنت تشتغل فيه. يعني مثلا عندنا في الجامعي مثلا ما عندنا كثير بيدياتريك imaging، لأن ما عندنا قسم الأطفال عندنا صغير جدا، فتعتبر لايت روتيشن، تجي تروق ما عندك شغل كثير. بينما النيورو لا عندك مرة بلكي، فممكن تجلس إلى المغرب. وبرضه يعتمد على الريزيدنس اللي معاك، إذا أنتم 3 أكيد بيصير أحسن من لو أنك لحالك وهكذا. بعدين الدiscussions اللي عندنا are equivalent for شو يسمونها نسيت الراوندز اللي يسوونها الأذر specialties على البيشنتس. we do discussions. إحنا كل مثل resident مثلا يكتب عدد معين من الحالات 5 CTs مثلا abdomen CTs، ويروحون كلنا إحنا residents خلصنا نروح للconsultant and we see all the cases together to have them approved for final reports. في centers كثير عندهم daily lectures. الحرس مثلا عندهم 2 daily lectures، إحنا عندنا one daily أحيانا تتكذب بعد. this is يعني your daily work، كذا حياتك. بتجي عشان تخلص شغلك وتروح، عندك lecture بتقعد، ما عندك ممكن تطلع بدري، يعني it's very flexible. بالنسبة للcall duties عندنا هي أكثر شيء مزعج في الراديولوجي. it is center based، يعني في centers في one on call first on call، زي عندنا في الجامعة ما في إلا one first one second on call، فالواحد أنت تغطي المستشفى كامل، كل اتصالات الانبيشنت والإي آر whatever بتيجي عليك أنت، بتستقبل كل هذه الاتصالات وتقرر إيش اللي تقدر تسويه وإيش اللي ما تقدر تسويه في الأون كول تايم. في سنتر زي مثلا الحرس عندهم 3 first on call لأن المستشفى كبير وعليه ضغط عالي، وهكذا برضو إذا صرت سينيور الكول حقك بيكون مختلف. You're not going to have إلا important calls. We're going to sift through everything the first on call writes، وهكذا. يعني حالات الأنكولات في الراديولوجي إنها بتخف عليك كل ما زدت في الليفل، بس الورك لود بيعلى عليك. طيب كذا بسرعة واي راديولوجي. أنا حاولت أفكر في شوية pros وشوية cons عشان أصير objective، عشان أعطيكم يعني true representation of the speciality. الراديولوجي من أكثر الأشياء الزينة فيه إنه flexible hours. زي ما قلت لكم يعني في سنترز كثير ما عندهم sign in ولا sign out، بيكونون بتجي إذا ما عندك شغل ممكن تطلع، إذا الكونسلتنت مو موجود أنت ما راح تسوي شيء. ففي مرة flexibility، والعكس صحيح يعني we have heavy rotations، خصوصا يعني في بعض السنترز اللي عليها لو زي مثلا تخصصي عندهم أونكولوجي سنتر، البادي اللي هي الأبدومن مثلا عندهم الأبدومن روتيشن سيئة جدا، وهكذا يعني على حسب السنتر حقك. من البروز حقت الراديولوجي إنه teaching based، فما كأنك قاعدة تسوي سيرفيس كثير. ليش؟ لأن الريبورت اللي تكتبه ما راح يطلع لأي أحد إلا في كونسلتنت موقعه لك. الوضع غير في الأنكوز طبعا، الأنكوز عندك privilege إنك تطلع ريبورت، بس في الديلي تايم مهما اشتغلت ومهما كرفت ما راح يطلع شغلك للناس إلا وهو approved by a consultant، وغالبا الكونسلتنت هذا he needs to discuss everything with you. وإذا أنت مو موجود في الأخير الكونسلتنت بيسوي approve للحالة حتى لو أنت ما كتبتها. إذا أنت يعني سهل مرة إنك ما تصير موجود، ما في اعتماد عليك كريزيدنت بشكل كبير يعني مقارنة بتخصصات ثانية. it's teaching based which is nice. تكلمت عن rotations اللي فيها light workload. في little patient contact، في ناس يحسونه برو، أغلب الناس يحسونه برو. ممكن تحطها في الكونز، ممكن تبغى patients وتبغى تتكلم معاهم، بس patient contact أكيد minimal. في الألتراساوند في الفلورو في البريست imaging أكيد في patient contact، بس بشكل عام it's very minimal. وحالاتها برضه إنه ما في rotations outside the field. الكونز radiation exposure هذه لازم أحطها كذا نفسيا، بس ترى radiation exposure is very negligible in radiology. وبيعطونكم أجهزة تحسب radiation، they're going to make sure that you're doing okay، يعني ما هو شيء يخليك ما تختار التخصص. مشكلة الراديولوجي إنه new، everything in it is new. يعني الإكسبوجر الوحيد اللي إحنا ناخذه في الراديولوجي في الميد سكول في سنة ثالثة طب، وخرابيط، يعتبر مرة خرابيط. you're going to read a lot which is very exhausting. غالبا هذا bulk of the work of a resident in radiology is to read and to know things، خصوصا physics. هذا من الأشياء السيئة يعني. stationary yes يعتبر desk job، صدق في وقفة في الانترفنشنال، في وقفة في الفلورو، في حركة في الألتراساوند، بس غالبا it's a stationary speciality. وفي كثير inter-center variability، يعني بتتعلم في سنترز غير عن اللي بتتعلمها في سنترز ثانية. في سنترز ما عندهم exposures، مثلا مدينة الملك فهد ما عندهم تراما، الشميسي عندهم تراما عكس كذا تماما، بس ما عندهم مثلا complicated cases وهكذا. فهذا شيء مزعج، بس عندك إمكانية إنك تاخذ electives وتطلع المستشفيات أخرى. بس كذا يعني حبيت أعطيكم كذا شيء brief. إذا عندكم أي questions feel free to ask.
بس شكرا لك دكتورة لطيفة. بقرأ لك الأسئلة وتجاوبين لنا عليها. الحين عندنا سؤالين، نبدأ في الأول اللي هو can you explain the path from residency to becoming an interventional radiologist؟
Sure. لو أرجع هنا نشوف التخصصات هذه اللي أنت بتمر عليها في كل سنة. you're going to have to go through all of these وتخلص part 1 exam وتخلص part 2 exam اللي هو في الأخير. بعدين you apply for interventional radiology fellowship. عندنا هنا في المملكة يمكن بس في 3 positions I think في الحرس وفي العسكري. إن شاء الله تزيد على وقتكم يعني. أنا في سنة واحدة زادوا position بس it's highly competitive. It's not easy to get into لأنه توه جديد عندنا. outside فيه interventional radiology residency program. ما تدخل diagnostic radiology أصلا، تبدأ على طول 5 years تخلصها أنت interventional radiologist. فهذا هو الباث. فيه interventional radiology اللي أتكلم عنه is the basic, the vascular interventional radiology اللي يسوون يعني كذا general things. النيورو interventional radiology is special. You have to go through a neuro radiology fellowship. بعدين after that a neuro intervention. نفس الشيء pediatric intervention بتسوي هذه الطريقة. وفي عندنا musculoskeletal interventions نفس الشيء. الباث for the conventional type of interventional radiology you're going to في السعودية يعني you're going to have to go through 4 years of diagnostic radiology.
جميل. في سؤال ثاني يقول لك عادي إني أروح راديولوجي وأنا حرفيا يعني ما يعرف يقرأ الراديولوجي أو
sure yes. وبعدين في ناس كثير دخلوا راديولوجي as a second option for them و they enjoyed it so much لأنه مو بلازم أنت مسوي electives قبل ومو أصلا حتى elective radiology للي منكم جربه مرة ممل ما تتعلم منه شيء. أنا عن نفسي سويت 3 electives ولا استفدت ولا شيء. ما صرت أقرأ إكس راي أحسن من الانترنز اللي ما سووه. فما في لا بالعكس إذا أنت صرت resident they're going to treat you as that you know nothing كأنك أولى ابتدائي يعني لدرجة إن أول 4 شهور ما في شيء ما في ولا عليك أي expectations. وحتى بعد ما تبدأ في الجونيور years مرة ال expectations are very very low من الconsultants ومن السينيور residents اللي معك في الأنكول. ف it's fine you're going to learn it's not an issue يعني.
جميل. أتوقع هذه الأسئلة. هل في أحد إذا أحد عنده سؤال يرفع يده؟ ممتاز. يبدو أن هذه الأسئلة. هل في شيء تبغين تضيفينه دكتور لطيفة؟
والله حياكم الله ولا يفككم يرزقكم ويحطكم محط مبارك.
شكرا.
اللي يبغى يتواصل معي يعني I don't mind I have my email في ال presentation تو. اللي يبغى ياخذ برضو من المنظمين موجود.
شكرا.
في question؟
شكرا جزيلا.
عفوا حياكم الله مع السلامة.
هناخذ السيشن الثاني إن شاء الله على الساعة 6 مع دكتور الدقة على الدرماتولوجي. الإيميل موجود في الكيوني أرسلت هذا. السلام عليكم دكتور تقى.
أهلين وعليكم السلام.
أهلا وسهلا. تقدر تسوي شير السكرين؟
تسمعوني واضح صح؟
إيه صوتك واضح. ممتاز طالعت لنا.
أوكي نبدأ الحين.
يلا توكل على الله.
Assalamu alaikum. Good evening, everyone. This is Toqa Al-Kaaf, KKH Dermatology Chief Resident, R3 resident. I will be presenting Dermatology Residency Program. We'll talk mainly about the duration of the program, and we have two pathways, the joint pathway and the KKH pathway. طبعا أول شيء, the first year, you get to rotate in different specialties. Medicine, we have medicine rotation, pediatric rotation, ER rotation, and elective rotation. You can choose either pathology, psychiatry. Plastic rotation now is mandatory actually. There is no promotion exam, and part 1 exam is optional. So no dermatology rotation here. Then in the second year, you start to have clinics and calls. Part 1 exam in this year is mandatory, and there is also another exam, which is the promotion exam. It's mainly a clinical exam. Third year, we have clinics on calls, and we have elective rotation, which is 3 months rotation. It includes pathology and surgery elective, dermatosurgery. Then there is only one exam, which is the promotion exam. Then the fourth year, again, clinics and on calls, and the board exam, which is the final exam. Training nature, we have first the outpatient clinic training and the inpatient bedside teaching. We have activities. In KQH, we have it every Thursday, and the joint activity is on every Tuesday morning. It's mainly book review lecture, basic science, therapeutic, and ground rounds. There is also dermatology pathology session, which is shared by both pathways every Thursday afternoon. There is journal club meeting, morphology sessions. It depends on each center. Participating in research projects is mandatory. Attending educational meetings, workshops. Okay. Here we'll talk about the consultations and the on-call. We have average 1 week per month consultation and on-call. The consultation service starts from 8 a.m. till 4 p.m. and the on-call from 4 p.m. till 8 a.m. Usually the first on-call is the junior resident, then the second on-call is senior resident or specialist, third on-call is the consultant. Sometimes it differs and it depends on each hospital. We have only junior resident or 1 resident and 1 consultant on-call. So we don't have a second on-call. Vacations, you have like each specialty, 4 weeks annual leave and 1 week educational leave and 1 of the Eid vacations. Fellowship opportunities, we have only 1 local program, laser and dermatosurgery in KKUH. What's the advantages of this specialty? You get never to sleep in the hospital, it's only home on call. Variety of patients, you see different patients, different ages and both genders. We rely on clinical diagnostic skills. Skin manifestation can be a sign of an internal disease. It's a rewarding specialties with curable or controllable disease. Patients rarely have life-threatening conditions. You get to do multiple researches. You can rotate in different hospitals, so you get to expose to multiple working environments, to see different patients and to work with different consultants qualified from different universities and countries, especially with the joint program. Different therapeutic modalities. We use multiple modalities: topical treatment, systemic treatment, immunosuppressive treatment, biologics, phototherapy, laser, and surgical therapy. We have different subspecialties: general, pediatric, immunology, photobiology, surgery, pathology, hair diseases, and venereology. Disadvantages: a lot of reading, busy clinics, and high competition with limited acceptance.
Lifestyle, workload, general residency programs are similar in lifestyle. The recognized difference is the home on-calls. Work environment is generally friendly, less colleague interaction and conflict, direct contact with the consultant. Misconception, dermatologists have no on-calls. We do have on-calls. Easy program and not stressful. It's not an easy, it's all new topics and difficult subjects. Simple cases, we don't have only simple cases. We have also emergency cases. Dermatologist uses topical treatment only. As I said before, we have multiple treatment modalities. It's important to know dates to plan your electives and to choose your internship track. So check it, they change it annually, every year. Application process, online application through the SFHC website. SMLE 50%, then the GPA 30%, and the portfolio submission accounts for 20%. Then after you get nominated to the interviews, you have the KKUH interview and the joint interview. Then every institution, they do their own interview to choose their candidates. Other sponsoring options, sometimes you can apply to different universities and they can sponsor you. Rank training center preference online. Then after that, every applicant, they can rank the centers according to their preference, and the centers will do the same. Selection through the matching system. Minimum score for nominated applicants. I couldn't find last year. لسه ما نزلوها على الويب سايت. هذا كانت for last year. قبل السنة اللي فاتت يعني. How to increase your chances? First, online application criteria objective, GPA 30% throughout your mid-school, CV 20%. It depends on the criteria, it differs each year. So you must start early to finish the criteria. Prior to your internship year, try your best. SMLE 50%, start preparing during the internship year. Usually it differs every year. Second, interviews. Plan your electives. You can take elective in the joint hospital and KKUH hospital for them to let them know you and to show your interest. Do multiple research. It's important to know to do it. And it's preferred to do in the dermatology field. However, it's not necessary. Volunteer work, campaigns, dermatology student club, conferences. Usually one conference is enough. They don't stress on it in the interviews. Practice common interview question and be yourself. Take recommendation letters from each hospital you join them during your internship. So, other options. If you didn't get accepted, you can apply at the postgraduate in each hospital. It's the best to contact the program director at each center for assistance. There are three options. Observership. Usually it's not accepted by the Saudi Commission, and it's available in almost all the hospitals. Clinical attachment, it's accepted by the Saudi Commission. There's no salary, flexible schedule, no on-calls. Usually it's found in KKUH, Prince Sultan Medical City, and Security Forces Hospital. Service, there's on-call and salary, but now it's only available in Shamisa Hospital. You get one more chance to enter the exam. You have to update yourself with the new regulation because it changes every year. There are multiple helpful resources, but at your level, you can start with Dermatology Essential Baby Bologna and the Fitzpatrick Clinical Dermatology. Visual DX usually also is a good application. And SaudiMedStudent.com and Derm Club also are helpful resources. Thank you. Any questions?
لك الأسئلة توها ما طلعت، ما حد طرح أسئلة، الحين يطرحونها إن شاء الله. اللي فيه عنده سؤال يبدي يرفع يده. ممكن تقولي لنا على بالي يعني ما يطرحون أسئلتهم، إنه وش اللي خلاك تختارين دنما personally يعني؟
First, I like dermatology since I like the dermatology since the fourth year. Because it has like different modalities or different subspecialties. like you get to see different diseases. There is not only like theoretical, also there is practical part where you can practice surgical dermatosurgery and laser, and it's fun يعني في variety of diseases.
جميل. طيب جانا سؤال يقول do we have any fellowship programs here؟
كان موجود في presentation إنه there is only one local fellowship program in KKUH. It's laser and dermatosurgery only.
جميل. الله. Why is the dermatology community so condescending؟ يعني is it necessary for me to become like that؟ يعني ما ادري هل عنده طباع سيء يمكن الشخص عن الدرماتولوجي كوميونتي. ايش رايك؟ condescending يعني يقول انه يعني طريقه تعاملهم شيئين شايفين نفسهم، هذا قصده.
لا مو كلهم، يمكن يعني he got exposed يعني to يعني not a friendly working environment، بس still يعني he didn't try it. He can try it in multiple يعني أو other hospitals. ممكن بالعكس تصادف يلقى ناس friendly ومو نفس اللي شافهم قبل، بس ممكن عشان stressful environment.
جميل. طيب يقول لي اسال سؤال كم في سيت في الKKUH؟
والله it differs every year. احنا على our year كان 5 seats بس usually 4 seats.
جميل. سؤال is the promotion exam as difficult as I've heard؟
Is the promotion exam ايش؟
as difficult as I've heard، يعني يقول هل الباس ريت بعد 20% فقط؟
لا ال part exam is more difficult than the promotion exam. Promotion exam it's clinical, so يعني الاختبار يكون على الأشياء اللي تشوفوها during the year يعني، بس it's not يعني that easy also. يعني comparing to other specialties ممكن تكون شوي أسهل حقتهم الإكزام، ويختلف من منطقة لثانية promotion exam.
ممتاز. جميل. طيب على بال ما تجي أسئلة زيادة يمكن أسألك كيف الانترفيو كانت معك، وكيف هل أسألوا أسئلة صعبة ولا شيء زي كذا، أو عندك أي نصائح لها في الديرما يعني خصيصا؟
الانترفيوز لا ما كانت مرة صعبة، بس هي يعني عندنا زي ما قلت 2 interviews، ال KKUH interview والjoint program interview اللي تتسوى بمقر الهيئة. Just try to be يعني confident, not overconfident, to be yourself, be friendly, accept يعني their يعني لو انتقدوك أو قالوا لك أسئلة شوي تزعل عادي تقبلوها. ساعات يشوفون الشخص يقدر يتحمل ستريس، يقدر يتحمل الانتقادات أو لا. كانوا يسألوا أسئلة يعني شخصية يشوفون طريقة تفكير الشخص فيها، يعني سألون على وقتنا على قيادة المرأة، سألون عن your favorite color, your favorite animal، أشياء كذا شوية عشان يشوفون شخصية الشخص. ما في أسئلة علمية عندنا.
ممتاز. جميل. يبدو أنه ما في أسئلة زيادة. هل في أي شيء تبغى تضيفينه نهاية النقاش؟
الله يوفقكم إن شاء الله ويكتب لكم اللي فيه الخير. بالعكس try your best to يعني enter your favorite specialty you get يعني you have more than one chance. حتى لو الشخص من قبل هذه السنة ممكن يجرب السنة الجاية، أهم شيء هو يكون حابب التخصص اللي يعني بيدخله. والله يوفقكم يا رب.
الله يجزاك.
دكتورة توكا، وصلتنا أسئلة على اليوتيوب لو عادي تجاوبينها معنا.
تفضلي.
يقول لك after nominations on what basis they match، يعني يقصد بعد ما ممكن في الانترفيو نفسها.
بعد الانترفيو قصده ولا بعد
يعني
قبل
بعد ما يصير النومينيشن البداية اللي هو على الاسم اللي وهذا، على أي أساس يختارون الكانديديت في السنتر؟
يعني based on your CV and the interview. وفي centers they care about the GPA و your SMLE score على حسب السنتر.
نكمل السؤال. يقول is it mainly cumulative base، يعني على المعدل بس؟
لا مو على المعدل بس. في centers اللي ياخذوا more than one seat ممكن ياخذوا مثلا واحد على المعدل والثاني على الCV والثالث على مثلا personality، تختلف. فمو بس على المعدل، بس mainly على الانترفيو والCV.
اوكي تمام. يعطيك العافية.
الله يعافيك، مع السلامة.
ان شاء الله بيكون معنا بريك من الساعه 7 ان شاء الله. راح يكون عن جنرال سيرجري مع دكتور احمد. السلام عليكم دكتور أحمد، تسمعني؟ ضبط معك دكتور أحمد؟
مساء الخير يا شباب.
مساء النور والسرور، يا هلا والله.
بسم الله. تعطيني شير سكرين الله يعطيك العافية.
الحين عندك القدرة، شوف.
طيب انتظرني شوي. السلام عليكم.
السلام. طالع الشاشة.
تسمعوني الحين؟ طيب.
إيه.
بسم الله الرحمن الرحيم. أنا الدكتور أحمد مدخلي, consultant hepatobiliary surgeon, program director of general surgery. Today we'll talk about the general surgery program in general and who should choose the general surgery as a future career, and how would you apply, where to apply, and what's the important things that you should consider when you apply to increase your chance getting to residency training program. The goal of the training of general surgery is, upon the completion of the training, resident is expected to be competent specialist in general surgery capable of assuming the consultant's role. The resident must acquire a thorough knowledge of theoretical basis of general surgery, including its foundation in the basic medical science and research. Who should go for general surgery? To be a GS or general surgery resident, this is one of the important things you should consider to assess yourself. Do you have all of these important or things to consider yourself as a surgeon, or to consider surgery as a future plan for you or no? This is not everything, but this might help you a lot in deciding. Number one is you should be great at working with your hands. It means that, you know, as a surgeon, most of our working is doing procedure with using our hands, incomparable to the other surfaces that they might use their hand to do the examination. But as a surgeon, you're operating with your hands, then your hands is very important for you. And you have to love doing this because we've seen some residents whom at the beginning they thought the surgery is the express specialty for me, but when it comes to reality, when they start the residency, they lean forward toward not to go to surgery. They like to stay in the floor, seeing patient, assessing patient, managing patient. However, they do like to operate more, which is not the character of surgery at all. Then this is a very important character of surgeon, that you have to love working with your hands to be a surgeon. Having to adapt does not intimidate you, which means that when you learn the surgery, when you learn the procedure, you have to, like when you start doing a cholecystectomy with me, then you learn some techniques from me. Then you go to another surgeon where he has his own techniques. Okay, if you work with him and he said, no, that technique is not my technique, then you have to be aware. You have to have a clear mind. You have to have an easy to change your technique, to assess, to adapt new technique. Till you became mature surgeon, then you can have your own way. Number one. Number two, when you operate on a patient, that in surgery, 1 + 1 does not sometimes all the time equal 2. Sometimes you do a great surgery, then you get faced with anomaly. Patient is behaving unpredictably. Patient has bleeding, you don't know why. If you follow a certain technique and you stick to that technique, you don't have open mind to change. You don't have plan A, plan B, plan C. Then it's not, the surgery does not fit you. Okay, you have to have a stamina, which means that you have to be capable physically and mentally to work for long hours in surgery and general surgery, especially because the general surgery, one of the specialty, or I would say the most specialty, surgical specialty that deal with unstable patient, sick patient. Patient is going to die if unless you do for him an urgent procedure. You may be awake during the on-call for 24 hours. You cannot space out during the procedure. You have to concentrate 4 to 6 to 8 hours sometime in procedure. If you're not the guy who can do this continuously, you don't have the physical capability of doing being awake 24 hours, attending procedure, doing procedure for sick patient, doing procedure middle of the night, then the surgery does not fit you. It doesn't mean that you're not good. It doesn't mean that you're not, you don't have the physical capability, but it's not physical capability of being a good surgeon. You have to enjoy working with other people. Surgery, one of the specialty that if you want to do the work alone, you cannot succeed. If you don't cooperate with the anesthetist, then you cannot do procedure at all. If you don't cooperate with the nurses in OR and with the nurses in the floor, you cannot, your patient will not have a good result. If you don't work and cooperate with the adjunctive procedure surfaces to you, like interventional radiology, endoscopy, then you cannot progress and exceed and excel in surgery. Leadership comes naturally to you, which means that the general surgery, usually I call it as a solitary campaign. It's like a soldier, but with good response to respect to each other. You have from starting your residency R1 to R5, you are doing some sort of leadership that sometimes you cannot, you don't see it. However, you're doing it. When you are R1, R2, R3, you're supervising the interns. When you are R4 and R5, you're supervising the R1 and R2. The general surgery residency, it's a seniority, which means that the senior is the one responsible for the team. The senior is the one who's going to run the team. The senior might be the one who's running the operation. If the senior cannot manage the team, if the senior is not a good leader, then he won't be capable of running a surgical team with him. You have to enjoy learning new things because, as you know, in surgery, it's dependent on technology. If you remember, maybe 10 to 20 years, the most of surgeries was open. If you have a strict mind or you don't accept new things, then you won't start to do laparoscopy. Maybe 10 to 15 years, laparoscopy were there, but if you don't have, if you're not open to learn new technology, you won't learn robotic. And again, the procedure itself, it changed between time and time. It evolved. New technique, new instrument are there. Then you have to be open mind. You have to catch. Otherwise, you won't excel in the residency and even in your future career. You enjoy seeing a concrete result. I think most of specialty are they enjoy to see a concrete result. However, in surgery, in general surgery, certain that you have a patient who is involved in trauma, he's going to die. You did for him splenectomy, you did for him liver resection, you did for him whatever procedure, then you said the patient gets survived. You won't see this amazing result for a patient from going to die to surviving, going home walking, and a lot of specialty. But you see this and a lot in general surgery because we're dealing with sick patients. You have a patient who's unstable, who has perforated bowel. You take him to surgery. If you maybe if you're late 1 to 2 hours, this patient might die. You go to surgery, you do for him a procedure, then the patient improve. You see the great result on this patient. This is what make a lot of surgeon, and this is one of the things that inspire me about surgery, that we seeing a concrete result on patient that inspired me to pursue the general surgery as a specialty. And in my opinion, this is the most important part you have to be willing to make sacrifice. And this is for you in the first 5 years in the residency training program. If you are one of those who are willing to make sacrifice, you will excel in your specialty. You might be, because the other specialty, they have their work start from 8 and end up at 4:30. They see if they have sick patient, they endorse this patient to the on-call team or to ICU, and that's it. However, general surgery, surgical specialty in general, and general surgery in special, no. Sometimes you have an operation that starts at 8, finish at 10 o'clock. You have to sacrifice your family, you have to be ready. You cannot say in the middle of operation, oh, at 4:30 I have to leave. No, this is not the way that the general surgery will work and will learn. This is one of the things. You might be like you plan your day after the working hour. I'm going to go with my family, with my friend. Then one of your patient gets sick, patient get leak, then you have to take him at 3:30, at 4:30 to OR. You get out from the hospital at 9 or 10 or 11, then this is general surgery. It's unpredictable on-call, unpredictable sick patient. You cannot say, no, at 4:30 I have to leave, my patient is not. No. This is how the surgeon should learn the procedure, because this procedure, it might not come again. If you don't see it in your patient, then you will lose a lot. That's, I think, one of the things that make the surgeon, if you are ready, if you are willing to sacrifice to some extent, doesn't mean that you forget your family, you don't enjoy your life, but you have to have the mind that I might stay in the hospital to midnight, even if I'm not on call. In some subspecialties, they might finish. They start around at 8 o'clock. They finish at 6 o'clock. This is the nature of their work. Then you have to be ready for all these things. Now, local program difference. Now, someone would ask, where should I apply? King Khalid University, King Faisal Specialist Hospital, National Guard, where? The difference between the local program are, in my opinion, it depends on the difference in the type of cases, number of cases, academic activity, dedication to training. Type of cases, you might go like one of the King Faisal Specialist Hospital, you won't see an acute cases, a general surgery resident that should see. This is one, I think, one of the drawback in general in subspecialized hospital in compared to the more of general surgery hospital. Number of cases, yes, you might see in one hospital 1 or 2 appendix per night, and in the other hospital the routine to see 4 to 5 appendix per night. This will increase the experience. Academic activity. I think one of the cornerstone to differentiate the hospital, one of the things is the academic activity. Academic activity, not all hospitals, they have dedicated academic activity where the consultants are willing to teach and sit with the resident, give them lectures, give them cases, discuss with them, willing to teach, and dedication to training. I think our hospital, one of the hospitals that are really, I'm not saying that we're the best. No, every hospital has its own strength and has its own weakness. طبعا.
دكتور، فيه المايك عندك ترى قاعد يتشوش، ممكن يلبس يمسك الملابس ولا شيء زي كذا، تبعد عنها.
تسمعني الحين؟
الحين ما في الحين ممتاز.
Okay, right. I'm not saying that our hospital is one of the best hospital. No, I think it's every hospital has its own weakness and has its own strength. But some hospital that they have like an minimum and maximum number of cases, type of cases, academic activity, and dedication to training that make them excel in their specialty. Like if you go to general hospital, you won't see subspecialty cases. You might see, if you do all residency in, like, let's say King Salman Hospital, you would see only the GS cases. You won't see hepatobiliary, you won't see a breast endocrine, you won't see a colorectal. You will see only the emergency and the regular general surgery. Therefore, you have to target the hospital that combine both. Combine the general surgery cases and combine the subspecialty cases. Hospital that, or the training program that have a dedicated academic activity that would help the resident to acquire the knowledge and the theory and in the principle of surgery. And not only this, you have to ask and search for the hospital that are dedicated to training. There is hospital where the consultants are really dedicated. The program are concerning about the product and about the training of resident. And there's a hospital there are not. Therefore, you have to look and assess and evaluate every hospital if it suits you or no. Now, what's the difference between the local and abroad program difference? There is, when we say local and abroad, when we say abroad mean it's either well-structured program that has been there for long time, like North America, United States, or Canada, or a program that is more or less are non-structured. If you want to compare the structured program to our program, then yes, that structured program has been there for a long time. They have a well-structured program. However, if you think about it in reality, that the resident who will go there are the excellent resident, the resident who are ready to sacrifice, who are ready for the residency training program. If you take those residents who's going there or who's accepted there and you put them in local program, more or less you have the same result. Therefore, yes, the abroad well-structured program have a well-structured program that have a minimum requirement for a surgeon to be graduated as a surgeon. However, the quality, the type of resident are also matter, and therefore in the local program. Here we're seeing that the good resident, they don't have problem in their residency. They excel, and then even they excel in their specialty. And almost in every hospital, if you look, you will see an excellent subspecialized general surgeon who was a graduate of local program. Then he did subspecialty either abroad or also local fellowship. Therefore, I think the one of main indication to the quality of residency is the resident himself. This is number one. Number two, the center, of course. And even when you talk about North America, the centers in North America are different. The quality are different. Although, yes, there they have a minimum quality requirement. And one of the things from my experience, be a program director for 2 years, I think if you have a strong policy and procedure that a weak resident, if he does not change, a resident who has a bad attitude that he cannot change it, you kick him out of the program, then you will maintain the integrity of your program. I think what's one of the main difference here and there they have a very strong structure and very strong policy that the weak resident, the resident that they don't want to change, they kick them easily. However, in our program, sometimes very difficult to kick resident from the program, and this is, I think, one of the things that make or decrease quality of some resident that we have. In general, if you want to compare the local program to a broad program, the broad program, the well-structured abroad program, they have a minimum requirement where the surgeon can be, it's either to graduate as a surgeon, or the one who does not fit this requirement, they will they will kick him out from the program, or they force him to change his specialty. I think we don't have this here. Therefore, the difference or between the abroad program and the local program is reside more in the resident and here and there. However, after the residency, if you want to compare, you might say yes, the resident of the abroad program better than the resident here. However, after fellowship, they are almost equal. Okay. Therefore, and nobody will still practice the general surgery. Most of the graduates now are doing the fellowship. Therefore, the fellowship will cover the weakness that my program did not cover it during the residency. Here is the timeline for the applicant when they apply to Saudi Commission, when they started to do the interview and the final ranking. Now, if anyone is interested to apply to general surgery or any specialty, they have to go through the General Saudi Commission. They have to apply, and they have a points or score calculated according to SLE, according to GPA and CV points, and then accordingly the resident will be ranked, and according to ranking, the resident will be granted to get into the interview of the hospitals or no. Therefore, you have to concentrate on the points that's very important and will increase your chance to get accepted in Saudi in the matching system. This is the score of last year for the resident who applied for the general surgery. As you can see here, every center or every city has the highest city for the minimum score where in Hafr al-Batin people. However, the highest score was in Jeddah. For 2019-2020, all accepted applicant to get in the interviews was 220. In Riyadh, there was 71 who applied to the hospitals. Now, the selection, how do we select our resident? Number one, after we get the names from Saudi Commission, we contacted the applicant and we review all, we asked them to send us the CVs, the GPA, the recommendation letters. We review it all. We start asking about the resident, the hospital they work in, and how is their performance. Then we give those residents, the applicants, we give them an interview. Usually the interview, it's in one day. However, sometimes we face difficulty to choose between, because we have only 5 seats every year. Difficulty, we have like 10 best candidates that it's difficult to choose between them. Then we give them second interview to help us to rank the resident, the applicant. Then we make our decision, we send it to the match and the resident. If the applicant choose the center and we to choose them, then we match. Now, if the applicant did not accept and he is really interested in general surgery, what he should do? You have two ways. It's either you get to other residency training program, and I don't advise this for a reason, because number one, you're taking a seat on a resident or applicant that was interested in this specialty. Because you have high score, then you exhaust or you utilize the seat for a while, then you left it, and this will affect also the program of that specialty, number one. And number two, you cannot change from the one specialty to another specialty unless after you pass 1 year and then accordingly if you want to change the program, then you have to apply again, and it depends on the local committee. They might accept or they might not accept it. What is best? Best you have to do a service job at one of the hospital, and for the specialty that you want, and even will increase your chance to get accepted again. I advise anyone who didn't get accepted, you do a service job and then you do attachment to one of the hospitals that you're willing to. If and this it may increase your chance to get accepted. What will increase your chance? You have to show us in the interview that you're really interested in general surgery, and then by doing the courses related to general surgery, okay, doing an ATLS, doing post course, doing laparoscopy, basic laparoscopy. Now you're introducing yourself that I'm really interested. I started my career early, even before I start the residency, which increase your chance in compared to people who did not do anything. You have to do a general surgery rotation in center that you're interested to apply. Let's say you're interested to apply in KKUH. Then you have to do a general surgery rotation in KKUH. However, you don't need to do it with the program director or the beauty program director. You can do it with other specialty. However, you have to show yourself to them that you're really interested, and they have to keep eye on you. Then they can support you with the opinion, because when we come to ask about all the applicant, the interns who work with us, we ask about them. How is their work, their attitude, their work, their attitude, and it's because it's very important to us. I don't want to have an excellent resident who has applicant who has really bad attitude, or an excellent applicant who cannot work in team player. Okay, that's very important for us, that we ask about everything. We ask the residents, we ask the nurses, we ask the consultants that they work with, and even we ask sometimes other subspecialty that the applicant work in, because we are very careful in selecting our residents, and I'm sure the other hospitals, they do the same. However, be smart. Don't waste your chances in one hospital. Let's say you're really interested in KKUH and we are really interested in you. However, I have 10 else that are almost the same like you, and I cannot choose all 10. I have to choose 5. Then you have to give yourself a chance in another hospital. And again, you have to show the interest in that hospital. If the KQH did not accept you, then you have to go to your chance in that hospital still very high. One of the things that increase your opportunity is doing research related to surgery or general surgery. And this is very important because it shows us that you're really interested in general surgery. The rotation in general surgery is 5 years program. R1 to R3 considered junior level. R4 to R5 is considered senior level. The junior level, 24-month general surgery rotation and 12-month non-general surgery rotation. ICU and ER 3 months, pediatric, plastic, vascular 6 weeks, and elective 6 weeks. In our hospital, we ask our resident to do a thoracic surgery because thoracic surgery is very important specialty that we need our resident to cover. Senior level, it's all general surgery rotation and composed of 24 months. This is one of the table that we arranged for our resident. We prefer in every junior level in R1 and R2 that our resident do 6 months of general surgery, 6 months of subspecialty. We don't want them to be away from general surgery for a long time. And we want them to finish the subspecialty or the rotation that our general surgery rotation. Usually we give the ICU in second in R2, and the ER usually in R1. R3, it's all general surgery. We allow them to do an outside rotation in other hospital like King Salman, King Saud, Shemesi Hospital, Prince Mohammed bin Abdulaziz, where they can see more of general surgery that is getting less in our hospital. At senior level, we allow them to go for 1 year outside and 1 year inside, usually 6 months our hospital, 6 months outside, then 6 months in our hospital again, 6 months outside. We don't want to lose the contact with the resident for more than 6 months to assess his progress and to see if he has difficulties that we can fix in short period rather than losing a resident for a long time. What's the subspecialty of general surgery? We can divide it into two, GS subspecialty and non-GS subspecialty. Non-GS subspecialty, pediatric surgery still considered in none that the till now Saudi Commission, they didn't have, they still accept the pediatric surgery fellowship after general surgery, although they are running their own residency training program, but still they accept pediatric surgery as a fellowship. Vascular surgery, it's all in Saudi Arabia, it's all after general surgery. Thoracic surgery also, it's all after general surgery. The general surgery subspecialty is hepatobiliary and transplant, acute care and trauma, colorectal surgery, personal endocrine surgery, minimal invasive and bariatric surgery. Why we divided to say GS and non-GS? Because the general surgery, although you're subspecialized, but you cover the general surgery on call, you still do the general surgery work. However, the non-GS is usually deviated from general surgery to their specialty. The routine work of the resident, it's inpatient care, outpatient care, operating room, academic activity. The on-call usually from 4 to 6, sometimes 5 to 7. Vacation, residents are allowed to get 30 days as annual vacation and 7 days as an educational vacation. However, we don't allow more than 2 weeks per rotation for the resident because we don't want him to lose a lot of time during that rotation. Lifestyle and self-satisfaction. And this is, I think, this is one of the most important factor that the resident or the applicant should decide early on before he or she choose the specialty. The lifestyle, we can divide it into 3: resident lifestyle, fellow lifestyle, consultant lifestyle. Because resident lifestyle is not an easy, it's heavy, hard working, a lot of sacrifice, reading, you need to read, you need to work, you might have an operation that finish at 8 p.m. and then you expected from you tomorrow to do a journal club, or we expect from you tomorrow to present a topic. Then you have to get out, when you reach home, you have to read, to prepare. And this is for the residency. Therefore, it's very hard working. The on-call is in-house on-call. And this is, I think, general surgery as a surgical specialty, or the specialty that the on-call is in-house. Because we're the first liner in dealing with the trauma patient. Therefore, if any patient has trauma, then general surgery has to respond quickly. Therefore, we have to be in hospital. Fellowship is more of concentrating on the subspecialty. General surgery, you're reading all 5 subspecialty, including vascular, thoracic, and the pediatric surgery. However, fellowship, you're concentrating on one subspecialty. Therefore, it's less demanding than the residency, and it's more concentration on specialized specialty, and it's more enjoyable than the residency. Consultant lifestyle, it depends. If you're working in a hospital where there is only 2 or 3 consultant and you're covering all hospital, then your lifestyle, the consultant lifestyle, is going to be difficult. If you're doing only general surgery or you're doing subspecialty, the consultant, the lifestyle will be also different. In general, the lifestyle of the breast and endocrine is the best, I would say, the best lifestyle of all general surgery if they are only working on a general and subspecialty, because the procedure is not long time, and the outcome is one of the excellent subspecialty. However, the other subspecialty are also enjoyable. Now you have to know what you want to do and where you're going to work, and therefore you have to, because if you have the residency, you finish your residency and you think that GS does not satisfy you, then you won't excel in your work. Like if you interested in heavy subspecialty, let's say hepatobiliary, where you operate on patient, you stay in OR for 12 hours, but you're enjoying, this is what you want. For me as hepatobiliary, nothing will satisfy me apart from doing pancreas and liver. Although it's long procedure, high complication, more stress, but this is what does satisfy me. Therefore, I'm happy doing this subspecialty. The other will look at me, what are you doing? This is long operation, I cannot withstand it. It's fine, but for me, this is what satisfies me, that therefore I choose it. You will see someone who's choosing trauma, and they cover trauma for 1 week. They come at middle of the night, dealing with sick patient. But when you ask him, he said, that's what only satisfies me, other does not. Therefore, you have to be very careful in choosing your subspecialty to look for the thing that make you satisfied and enjoy it. Now, we talked about it, the fellowship opportunity, pediatric surgery, vascular surgery, thoracic surgery. We have it here as a local fellowship, and you can do it as an abroad. General surgery, we have all subspecialty as a local fellowship here, except hepatobiliary. It's only one center that they do it, King Faisal. We're almost going to open one fellowship soon, maybe next year, as hepatobiliary. But most of the other subspecialty are the fellow or the resident can do it in here. That's what I have, and I'm ready to answer your question if you have.
Thank you so much, Dr. Ahmed. We received some questions in Q&A.
Sure.
Availability of trauma center at the hospitals, does it affect the quality of training for residents?
Sorry, again?
Availability of trauma center at the hospital, يعني وجوده من عدمه, does it affect quality of training for residents?
Of course. Now, when you say the availability of trauma, then if you look at it, yes or no, I would say you cannot say yes 100%, you cannot say no 100% for a reason. If you have a lot of trauma that going to center that is not specialized, okay? A resident will not be trained on the proper trauma patient. He will not have the proper training, okay? You could, however, if you go to a center that maybe the number of trauma cases less, but you have a very dedicated team that you can see the difference in the management, you can acquire the knowledge and the approach to a trauma patient, then I think this is what matters. It's not the number of cases rather than availability of dedicated team that they can teach you and they can show you the good and excellent approach to trauma surgery. And I can see, and I can proudly say here that we have one of the, I think our hospital, one of the centers that have very dedicated trauma surgeon that we can see now the difference in the management of the patient, of the trauma patient. Okay, if I think the quality rather than the quantity.
Great. Another question, what are the acceptance chance for a non-Saudi from a Saudi mother?
Well, this is now the acceptance. You will the candidate who who or she is not, he or she is not Saudi, but her mother is Saudi, is accepted in Saudi commission, okay? And then she will go for the interviews. That some hospital, they have their own policy where they prefer to have a Saudi candidate rather than a non-Saudi from mother of Saudi, okay? But however, most of the center, they don't differentiate. They depend on the quality of the qualification of the candidate.
أوكي. في سؤال يقول خلال السنة الماضية نظرا للجائحة ما قدرنا ناخذ الليكتيف، فكيف نقدر ممكن نثبت نفسنا بأكثر من مستشفى بنفس الوقت؟ لو عندك نصائح يعني في هذا الشأن.
This is one of the difficulties, to be honest with you, because when I have a resident or applicant who came to me and apply for general surgery, but I don't know anything about him, in compared to an applicant that he worked with me, he showed me his interest. I saw his work, I saw his attitude, I saw his concentration, then I will give more opportunity to the resident that I know, the applicant that I know more than the applicant that I don't know. How to solve the problem of the Jaihat Corona is very difficult. And I know there is a lot of people will be, a lot of candidates will be affected, but one of the things that you can approach the hospital that you want to apply to, and you can maybe ask them for a research that we're ready to do a research with you. And one of the things that I've noticed that if you do, let's say you want to do a general surgery in King Faisal, however, you didn't have rotation there, okay? But you did rotation with me, okay? Then you can ask me to write for you or to call for you, the program director. Hey, we have a resident, applicant that is an excellent, he's interested in your hospital. I really advise you to do this. We ask, for me as a program director, I ask other consultants of the other hospital, how is this resident, how is he work, how is his work? We ask also the resident of the other hospitals that how is this the applicant work, how is his performance? And this is, I think, one of the things that the resident, yes, you won't be able to do a rotation for in every hospital. However, when you do a rotation, you have to prove to them that you're excellent and you're doing your work. One of the things that is very important, I've seen a lot of now or let's say an intern, now they are interested in general surgery. However, they are doing nothing in their rotation. Now, you might come to hepatobiliary rotation and I have 8 interns with 2 patients. How do I assess this applicant if he's good or no? And I think one of the things that the resident should be careful about it, when you choose your rotation, you have to choose it in a rotation that has a lot of patients to see, does this fit you or no? You have to do it in a hospital where you have to work 24 hours and see, does 24 hours, can you withstand 24-hour work or no? Okay. You have to go to hospital, let's say King Salman, Prince Mohammed bin Abdul Aziz, where they depend a lot of on the intern, and they give them a lot of work, and they see how is the work there. Okay. However, let's say doing only in KQUH with less number of patients, then actually you're destroying yourself rather than approving that you're good to pursue general surgery. And this is my advice to my intern and my advice to every resident. You have to pursue the internship rotation in the heavy work hospital. I remember during my internship, I worked in King Fahd National Guard and Shemesi Hospital. And not only this, I tried myself to stay 24 hours to see if I can withstand this or no. And this is what make me a love of general surgery. And I cannot accept any other specialty because I tried it. I tried the heavy part of it and I like it.
Okay, ممتاز. في سؤال يقول the number of resident seats is huge compared to fellowships or consultant seats. فإيش الفate of residents who has not obtained acceptance in a fellowship?
In a fellowship, they have to
يعني.
do yeah, and what I get from you that the number of graduate a lot and number of fellowship less.
Yes.
What should I do? Now, there is 2 or 3 kind of graduate, and one graduate, he has his own specialty. He cannot do anything else. He can wait for 1, 2, 3, 4 years, but he won't see himself doing other than this specialty. And this one is very clear, and I think he will have it at one time. The other one, he's open for any specialty, okay? And this one, he will apply, let's say he finished the general surgery, then he apply for hepatobiliary, acute care, colorectal, whatever he will get in. This one, he will get more chance to get into fellowship, but it's very danger to somehow, because he might get to a specialty that he does not like, and then after that he said, oh no, you know what, this is not my specialty, then he starts to pursue another one. Okay, and there's some resident who said, you know what, general surgery finished, no more, I will practice as a GS. And most of those consultants, they don't stay in Riyadh at least, or they will stay in hospital where the subspecialty is not needed. Okay, for this is yes. Outside, there is a lot of fellowship open in outside. And again, fellowship and residency is resident and fellow is directed. If you are an excellent, if you know what you want, then you can work, you can go to any fellowship and you can excel there. Fellowship outside is still open and you can get acceptance anywhere. Germany, France, Korea, North America still is open. Local program is increasing now, and the number of fellowship increasing now. However, you have to be very smart in choosing your specialty.
ممتاز. في سؤال يقول, if I'm really interested and my CV is good but my GB is not very high, can I be accepted?
Yes, we don't depend on now. Number one, I cannot accept any resident if he didn't pass the ranking, the first ranking by Saudi Commission. However, if he passed the ranking, now here we can we can assess the resident. Yes, the GPA reflects that how is the resident is good during his college of school, but we've noticed that we have a star applicant that they have a very high GPA, but actually they don't fit in general surgery at all, or they don't work in teamwork, or they have bad attitude. We don't want those. Okay. I rather have an applicant with average GPA that is really interested. He work in team player. He is a good team player, and he has a good attitude. This one I can guarantee that he will be good. The other one with high GPA but with bad attitude, or he cannot work in team player, I'm sure he will not succeed in his residency. Therefore, yes, the GPA can reflect part of your increase your chance, but however is not the main determinant.
ممتاز. في سؤال يقول, does lack of GS research affect the acceptance despite having many GS electives and documentation lectures?
It decreases but does not diminish it. Okay.
Okay.
It decreases, yes, because now if I have ex-resident who is doing research in general surgery and resident who is not doing research in general surgery, okay, most likely the one who's doing research in general surgery is more interested than the other. However, research is not the important thing for us. When we assess the applicant, at least in our hospital, we don't take one factor as determinant. No, we take them together. We might have one with average GPA, but he shows us an interest in research, he shows us an interest in work, he has a good attitude, then we might accept him. You might have one applicant that he did an even meta-analysis, but actually he's not working well as a team player, he doesn't have a good GPA, then no. We take it all together to rank our applicant.
Okay. في سؤال يقول can you please repeat the courses that we should take?
The important course and that it reflects, number one, it show interest, it increase your chance, and that I can see from it that you're really interested in general surgery. Is an ATLS course, post course, basic surgical course, and laparoscopy course, basic laparoscopy course. And believe me or not, surgery in general, general surgery in specific, yes, I can teach you how to do cholecystectomy, but if you're not practicing how to do knot at home, how to do skin suture at home, how you don't have you're not practicing in the dry lab a lot, then whatever I teach you will not increase will not improve your skills. You have to do a lot of things outside the OR to have the chance to progress more. Therefore, it depends on the resident rather than in the center. Center, yes, it helps. Center, it has it directed you. It improves your skill, but the work that you're doing outside is really very important.
Great. تعقيبا على سؤال نان Saudi from a Saudi mother, does their chance to accepting KQH is high? قلت إنه يعتمد على السنتر يعني.
يعتمد على السنتر yes. طبعا البوليسي تتغير every time. Usually here they prefer Saudi rather than non-Saudi, and I think it's related maybe to policies here, but it's not I would say it's not the main determinant. Okay. Some program they accepted or Saudi, non-Saudi from mother Saudi.
Okay. What's your advice to show the interest يعني إذا شخص مرة interested في surgery?
Number one, you have to do your rotation in a rotation that can show your work. Okay. If you have let's say you're doing a rotation where the number of patients is 5, and you're doing a rotation where number of patients is 25, which one will show your work, the 5 or 25? The 25. Why? Because I want to see that you can handle a lot of patients, and you can handle the stress of assessing a lot of patients. You come early, you leave late. You're reading about your patient. You're actively involved in the patient management. Okay, this is one. Two, will show you, does this specialty fit you? Because at the end, I don't want to accept you, and after 1 year you come to me and said, oh, I think general surgery does not fit me. I tried for 1 year, and we have like last year, one resident have changed from general surgery to family medicine. One resident changed from general surgery to ANT. Another resident changed from plastic to general surgery. We don't like this transfer, but it seemed to be when they decide they didn't try it well in a well and good center. So therefore, you choose a specialty where they have a lot of patients. You can show your work. You have to do the rotation, and you have to try more than one center. Okay. And you have to show, you have to test your chance, which center, then you work on it, involve yourself in research of general surgery, and you do the basic the courses that we talked about, and involve yourself in the activity of the general surgery. This way you're showing me that you're really interested in general surgery. However, be careful. You have to be a good team player. Number one, you have to have a good attitude. Number two, okay, this is very important to us when we consider accepting an applicant to our program.
Okay. recommendation letters all should be recent in year of internship, or they could be from different years. يعني which one is better?
I will tell you. See, recommendation letter and I have during the internship, a lot of resident interns, they come to me and said, we need to have a recommendation letter for you. Okay, recommendation letter, if it's either a paper that will support you very hardly, okay, or a paper that is like the other papers, okay?
Mm-hmm.
And it mean what? It mean if you work in a place or in a center or in a rotation that you show them your work, they are amazed by your work, and they give you the recommendation letter, then will help you a lot, okay? Because during reviewing the applicant, every applicant, they have their own recommendation. But we knew which recommendation it's really strong that we can accept it, or which recommendation that was given to intern because they work. Therefore, choose the specialty or the rotation that you really work in it hardly. The team have seen your work, and the consultant really support you to get accepted in any center. Number one, it has to be, yes, recent, because if I have a question about you, I will ask this one who gave the recommendation. They have to have like email or anything that if we want to ask, then we can communicate with them. If I send like an email asking about X applicant, and the consultant who gave the recommendation said, "Oh, I don't know him," or I just give him like other interns, then it means that he wasn't impressive to consider the recommendation is very strong.
Okay. في سؤال يقول إيش الأسئلة ممكن تواجهني بالانترفيو؟
The interview, we want to know if you're safe. Your thinking process is a safe thinking process or no. Number one. Number two, I want to see if you're a team player or no. And number three, I want to see, are you planning for your career? Because what we've seen, some applicant, they really worked hard, but their goal to get in the residency, once they get in, you see a completely different one, okay? We hate this kind of resident. Why? Because they don't have the system to continue what they reached to. Yani, he worked hardly to get in the residency, he should continue. Some of them, no, they drop, okay? So therefore, you have the applicant should sound clearly that he planned his future. When I have an applicant, if I ask him what you want to do, what you're expected from general surgeon, and he give me what he expected based on he asked about the specialty, how his perception about the specialty, where he can see himself after 5 years, I know this resident is ready to start the residency, or this applicant. Others, no, I don't know what to do. I don't have my future career yet. Some resident, why you chose general surgery? He said, I've seen a resident, I asked him, he said, good, then I chose general surgery. It tells you that he does not have a clear future career. Therefore, this is a tricky question. Even also, you have to be very careful. If they give you a very difficult scenario, you have to work as a clearly intent that you have to report this one to your senior. You have to communicate with your senior. You don't take an action that show the interview committee that no, you're very dangerous of approaching those patients.
Great. في سؤال يقول what are the heavier hospitals من ناحية الGS يعني?
It depends. I cannot talk about the other hospital. Okay. What I'm talking about our hospital here is that we have some services that very heavy. However, they teach, and the resident will they learn usually. And we have very soft, or I would say less heavy surfaces. Okay. And the other hospital, I don't know. طبعا when you talk about heavy, you have two things: heavy in on-calls or heavy in work, or both. Okay. In my opinion, the hospital that heavy in work and heavy in on-call is the best hospital to learn. Okay. If you have hospital that is lax, they don't have a lot of cases, they don't have a system, they teach you how to be not to be committed, not to be dedicated, then believe me, whatever you get during residency gonna be reflected on you during the after you finish and fellowship, and the after you finish the fellowship. Therefore, you have to aim to the hospital that have clear system, okay, that monitor your work, monitor your dedication, have a clear academic activity, and they are really dedicated to teach and train the resident.
في سؤال هنا يقول how many on calls per month في ال KQH?
How many? احنا هنا as a junior level from 5 to 6, average 5, sorry, from 4 to 6, average 5, sometime reach to 6, sometime stay at 4, it depends on the number of junior residents. We're trying our best to decrease the number of residents because that will increase the exposure to the resident. Senior level usually it's from 4 to 5, usually at the 4.
أوكي. في سؤال يقول أقل نسبة مركبة انقبلت بالجراحة العامة بالجامعة السنة الماضية.
I cannot remember, to be honest with you.
Okay. Last question. Best centers for GS Riyadh according to your opinion?
Of course, I would say KQH. That's for a reason, because I would, I don't take it from one aspect. If you tell me I want a hospital that has a lot of cases that give me a lot of cutting, I would say KQH maybe is not this hospital. Okay. However, KQH, it's, in my opinion, that's why I said type of cases, number of cases, academic activity, dedication to training. You could work in a hospital where you can do 5 appendectomy every night. Your skill gonna be excellent in appendectomy. However, you don't have exposure to advanced surgeries. You don't have exposure to, you don't have the clear knowledge how to treat the complication of surgery. You don't have the experience how to do an advanced procedures. Then if you're a type where the cases only satisfy you, then you could go to more of the general surgery hospital. Okay. However, we've seen a lot of residents that come to our hospital. They said, I have never seen hepatobiliary cases. I have never seen personal endocrine cases. This is not the scenario here, because our hospital, we have the all subspecialty in general surgery, number one. And number two, yes, the number of cases during on-call is variable, but we have a good number of cases, two. And number three, in my opinion, the teaching point of the cases is really important. You could have 2 cases that you have a very detailed teaching, better than having 10 cases with no teaching. And last thing is the dedication of the consultant to teach. You could have a hospital where they have a lot of cases, but the consultants are not free to teach. And instead of having a hospital where, yes, they have their number of cases may be less, however, the consultants are really dedicated to teach the resident. They can stay with them for a long time. And one of the things that I'm really proud of, that our success rate in the board is very high, number one. And number two, we support our resident till the last day of their residency. We are one of the hospitals that we do a actively session for our resident who's preparing for exam till they go in their exam. And we've received a lot of requests from residents from other centers. Please, can we join your activity for your resident? And in our center now, Jamiat Noura, they are joining our activity because they believe that is well structured and directed to the resident. Therefore, in my opinion, حيكون biased, but I think our hospital one of the best. هذا لا يعني the other hospital are not. The other hospital are doing great job, but I cannot judge them because I'm not there. I cannot see their work. I cannot see their activity. I cannot see how they give their resident and how they teach the resident.
Thank you so much دكتور. هذا آخر سؤال كان أخذنا من وقتك، يعطيك ألف عافية.
حياكم الله، توفيق إن شاء الله.
Thank you for all attendees and see you tomorrow إن شاء الله.